Welcome to the Critical Care Nursing Webinar Session 2. I am Dr. Noormahal Kabani, and our presenters today are Shabana Ali and Dr. Mohsin. Next. Welcome to the Critical Care. Before we begin the actual seminar, I'd like to go through some housekeeping information. You have your handouts at appnamerit.com under Nursing Webinar Resources. The webinar is also available on the YouTube video channel, and there will be a live YouTube video also going on at the same time of the seminar if you lose connection. I would like to bring your attention to the feedback forms that are also in the on the APPNA Merit website. And also they will be sent to you by chat by Dr. Mohsin in just a little while. Through the seminar, please fill those out. These are essential for us to understand what your needs are and whether we are meeting them. They would also be required for the e-certificate. One more item, this webinar was supposed to be 8 weeks. We have extended it to 9 weeks, and the last session will be a review session with Q&A and multiple choice questions, so that you get an overview of the entire seminar, all the 8 seminars. Next slide, please. Okay, so there were some questions from the last talk, and I'm going to kind of quickly go through some of them. Some of them were answered. There was a question about explain more of the assessment of the lobes of the lung. There is a handout as well as some audio clips in your handout that you can go through. The lobes of the lung, as you know, there are 3 on the right, 2 on the left, and if you auscultate all of them, then you can tell, you know, where the problem is. In our patient, the left lower lobe was affected, and possibly you could hear some crackles or some dullness to percussion when you percuss over the left lower lobe. So you can go through those handouts, and if you have any questions, please feel free to ask us. Next slide, please. Okay. And how much time do we spend in head-to-toe assessment and how to document the assessment? Well, the documentation depends on your hospital. Different hospitals have different forms that they fill out. We can show you a sample form. As far as the head-to-toe assessment timeframe is concerned, you should be able to do that in 10-15 minutes or so, possibly longer when you first start, and Shabana can probably tell you a little more about it when we get to her if she would like to comment. The other question was, I think there's a sample form, Mohsin, if you want to show it to them, if it's available right there. This is in your handout, okay? So it goes system-wise. Next slide. The previous slide, I had said that metformin should be stopped as it causes acidosis. Then what will be the next plan for diabetes management? Good question. The point is that metformin is not the drug you use in any acutely ill patients. What you do in the hospital setting is you use sliding scale insulin or IV insulin for several reasons. One is much easier to control, very predictable response. But more importantly, metformin is a drug that in a state of dehydration and acute illness can add to lactic acidosis and cause dehydration. So you do not want to use metformin. Alternative in the hospital is insulin, even if your patient is on an oral agent. And then when the patient's ready to be discharged, you can decide on a plan of care for the patient. So I hope that answers the question. I'm sure, is there another question at the end? Okay. So there's going to be, this is the question that was from the last session, that Mrs. N has a natural airway, O2 sat was 93, room air upon admission to ICU. At the end of your shift, you assess the patient, and now you have these 4 issues. Which one of these is not of increased concern to you? A respiratory rate of 26 per minute, capillary refill less than 3 seconds, that the fact that she's sitting up in bed and appears anxious, and the fact that she has nasal flaring. So please choose your answers.
So you will get 30 seconds to do this.
30 seconds for you to answer that. And there is only one correct answer. The question is, which one of these findings is not of increased concern to you? Did we get any answers back?
We did. We have got 75% of the people who have said that its answer is B.
Wonderful. All right. The seminar is over. You guys know it all. Well, no, that's good. Just a quick thing. Apart from nasal flaring, the signs of respiratory distress are many. If the patient cannot speak in full sentences, you need to pay attention to that. If you have nasal flaring, if you have a tracheal tug, if you expose her belly and her chest and you see intercostal muscles working very hard or the abdomen working very hard, all those are signs of respiratory distress and you need to pay attention. I'm going to now hand it over to, because this patient is developing this, I'm going to hand this over to Shabana and Mohsin so they can take care of the patient next.
Go ahead, Shabana.
Okay. Hi, everybody. This is Shabana Ali. I'm the Associate Director at Houston Healthcare Southeast. This facility is based in Houston, Texas. So we are glad and very happy to be here to be part of your learning towards the journey towards critical care. So welcome to you all.
Wonderful. And my name is Dr. Mohsin. I'm one of the consultants in critical care. And I think that's enough. We will keep on with the talk at hand now.
All right, so I'll take over from here and we will go through some of the objectives that we are going to achieve through this webinar today. Some of you might have joined us in our webinar, the first webinar, and we mentioned that we will be continuing with the case study that we started in the first session until all the journey that we're going to have until week 8 or week 9. So as Dr. Noor mentioned that the patient has been admitted to ICU and all that. So we were just going through what's happening with the patient and in webinar 2 with us, okay? So we're going to be reviewing some of the signs and symptoms of Mrs. N, and then we'll summarize the nursing assessment that we did in the session 1. We will go through the basic anatomy and physiology, and Dr. Mohsin is awesome into that. So he will be explaining some of the important points that we have to remember when we talk about the gas exchanges at the alveolar level. We will be listing some of the situations in which the oxygen and carbon dioxide get compromised. They cannot get exchanged very well. And then we will be discussing some of the oxygen modalities. What are some of the ways we can provide oxygen to our patients? We will be really touching on the oxygen toxicity, but not in details. We will be putting a handout about the oxygen toxicity because this is one of the important topics. But because of time constraint, we will just put the handout on the shared drive. And then finally, after reviewing all these, we will evaluate. So what is the best oxygen therapy for Mrs. N, looking at her vital signs and all her labs and everything. And we will be discussing some of the nursing care of patients and she will be put on BiPAP therapy. So as we know, that patient was in ICU. She came to ED in ICU and now he has the diagnosis of diabetic ketoacidosis. So she wasn't, just to recap for those who were not there in the first session. So we had a 68-year-old female who came to ER with a past medical history of diabetes, asthma. She has hypertension and hypolipidemia, and she came for the fatigue and verbal complaint of shortness of breath for 3 days. So, and she was on the lipid medications, metformin, that we discussed about those medications just quite a while ago. On your examination, when she came to ER, you found that the patient has a temperature of 38.4 degrees Celsius and her heart rate is 110 beats per minute. You checked her glucose, that was 687, and you did the UA of urine and you found some ketones. And then I think it should not be a surprise. Now she was done the COVID testing and she was positive for the COVID. So as I said, she's in ICU now with the diagnosis of DKA. Next slide, please. So as we learned in our session 1, no, the previous one. how quickly we can assess a patient when the patient comes to you. Either it could be an ER, it could be an ICU. The assessment is one of the key component for a nurse when she is initiating any care. So we learned about ABCDEF bundle, ABCDEF model, one of the model that we use to have a quick glimpse of the patient. So as we say, A is for the airway, so we know she wasn't in room air. B is for breathing. We say she was breathing with a rate of 12 per minute, and it was not a labored one. She was fine, breathing smoothly. And then C is for the circulation, in which her heart rate was 113. She was sinus tachycardic, and her skin was warm to touch, and she has 2 IV cannulas for any IV medication. D is for disability. So we say, and any pain. She was complaining of mild abdominal pain, and she said it's 3 out of 10 scale. So that was not very, very severe pain that we could do anything at the time. E is for the exposure. So we saw the skin and the wounds, and everything was normal. No skin, no rashes, everything was fine. And the fall assessment that we do on every patient, she was moving steadily, slowly, but she was able to stand on her feet. Next slide, please. So when she was brought to ICU, and as a protocol for ICU, the ICU nurse did a head-to-toe assessment. So we just summarized the assessment in the system-wise, and you saw the patient was from a neuro, because you always start from the head down to your toes. So from neuro, you say patient was drowsy, as we mentioned, she was moaning, you know, and but she was oriented, okay? She was moving all her extremities. Her GCS was 15, little anxious at that time. So very important, the pulmonary assessment that we did, we saw she was fatigued because she was complaining of shortness of breathing. She was tired of breathing. She was also coughing a little bit. And when you auscultated the lung sound, you found that the lung sound at the bases, lobe, bilaterally were kind of diminished. You were not able to hear a pretty good air coming in and going in and out of the lungs. You found the potassium that we did in the emergency, it was 3, and the chest x-ray the doctor ordered, that you found that it has some very hollow area, there's some atelectasis. The alveoli were kind of closed, so you see some patches on your x-rays, especially on the lower bases. Cardiac wise, as we said, patient has tachycardia, cold clammy skin. She's complaining of GI 4 pain out of 10. But no, some nausea, but no vomiting or diarrhea. And in ICU, when she came from ER, you saw that the temperature is 37.8, but the heart rate has increased now, 120. Respiratory rate is increased, 32. And now she's using some accessory muscles to breathe, and her oxygen saturation has dropped to 90%. And the blood pressure is kind of a borderline to 105 by 72. So in the ER, she was stable. She came to ICU. You took over on this patient, and you did the head-to-toe assessment, and you found all these assessments. Next slide, please. So we can say what's going on with Mrs. N. So yes, of course, looking at the oxygen saturation, she's anxious, cold, clammy skin. She's breathing more. She's tachycardic. So yes, her oxygen is getting compromised. That means she's not getting enough oxygen in her lungs at the alveoli level to go into the whole body. So I'm going to hand over to Dr. Mohsin, who's going to be discussing us how actually oxygen and carbon dioxide get exchanged at the alveolar level, which is a very, very important feature, especially when we talk about any COVID patient, because all our interventions are based on that. Thank you.
Mohsin, you're muted.
Mohsin, you're muted.
Unmute my audio. Apologies. Let me start again.
Okay.
So whenever you have somebody who has presented or who looks anxious or short of breath, be wary that don't just label it as anxiety. It might be that there's something going on. And whenever you see these symptoms, move on to certain signs that you specifically start looking for. Things like tachypnea is an early sign. An inability to complete sentences, as Shabana has mentioned, use of accessory muscles, that they have said, and low saturations on a SATS probe. Cyanosis and drowsiness are late signs of low oxygen levels. And ideally, you should not end up in a situation where you are seeing those signs, but be very, very wary. that waiting for those might actually, you might miss the boat if you keep on waiting for those to say this is cyanosis or this is hypoxia. So when somebody is not getting enough oxygen, there are two things that you have to think about. How can I address the problem right away? And what's actually causing the problem and what's the treatment for that? Now, what can I do right away is the part that Shabana is going to cover later on in this presentation. I'm going to talk about how to figure out what's going on. Okay, so that's what I'm going to focus on. So some basic information. You can see the airway, and you can see that normally oxygen is going through the nose up to the upper airways and down the trachea into the lungs. Yes, and as you could see, almost 21% of what is being inhaled is oxygen. And there's literally even less than 0.1% carbon dioxide in normal inhaled atmospheric air. The other thing to keep in mind is that water gets added onto this mixture early on. And that brings us to our first question. So where does humidification start? So again, you have 30 seconds to respond, and then we will end the poll. Ah, wonderful. So as we said, we are going to give it 30 seconds. Time does fly. Okay, 30 seconds are done. And 85% of you have said nasopharynx, which is the right answer. Some of you thought oropharynx. Air does get humidified in the oropharynx, but that's not where it starts. And some of you said trachea. So no, trachea is the way down, and oxygenation really starts in the nasopharynx in somebody who's breathing through their nose. And that brings us to the next question. So further down, you've gone down the trachea, and now you're going through the rest of the bronchial tree to, rest of the bronchial tree to go down to the level of the alveoli. And as you see, as air is going down, you're finding that the water content is getting higher and the carbon dioxide content is getting higher. But the oxygen concentration is going down a bit. It has gone from 21 to 19%. And then we go to the next space. How much air does a person inhale in a breath? So we are looking for an amount here. And that is going to be the next poll question that's going to prop up in front of you. With the idea, if you can tell, what do you think? 500 ml, 200, 300, or 150? So again, 6 more seconds. And I'm glad to say that 76% of you gave 500 ml, which is the standard answer that we normally give. Of course, the volume depends on the patient's size and other things, but we will go into the details of that when we talk about invasive ventilation. So that leaves us to the next question. What happens when the air actually gets to the alveoli? Now, as you can see, the oxygen concentrations have gone down to 15%. And even though water and carbon dioxide levels have gone much, much higher, it still doesn't tell you what's the rest of the gas made of. And actually what you need to know is that nitrogen is the major gas in the alveolus and the rest of the atmosphere that we don't use for oxygenation in any kind of gas exchange, but it has an essential role. And I'll explain that later. So, but here's another concept that we need to make sure you understand, which is what is dead space? And again, the poll has now appeared, and if you can answer some of those questions, that'll be very kind of you. Okay. Ah, wonderful. So this is interesting to see because there is a disparity 38% of you have said that the part of the airway that is above the larynx. And another 38 have said that it's airway from nostrils to the bronchioles. Well, dead space is any part of the airway which does not take part in gas exchange. So anything really above the alveoli is not really taking part in oxygen being transferred from the lungs to the rest of the body. And that is a concept which needs to be understood well, because when you're going to talk about ventilators in the future, you need to understand how much of the air going in and out is actually contributing to patients getting oxygenated. Okay, so we go to the last part, which is very much a focus on what different layers the oxygen has to get through to finally get into the blood. And as you could see in this little diagram here, the thickness of this is quite small, but that will change if you put more water there or it swells up. It's the layer which is the surfactant, the epithelial or the endothelium underneath, the plasma underneath that, and of course the red blood cells, which will carry that oxygen to the rest of the body. Now, a lot of things can go wrong, which can stop people or stop that oxygen easily getting from that alveolus into that red blood cell. And we will talk about that in a second. And here we go to the next bit. The next question is, which of the following can affect the amount of oxygen getting into blood? And here there are only 3 things that we are looking for. And you can give multiple answers here. Okay, and as you, well, most of you got it right. I suspect the poll only allowed you to answer, give only one answer, but all 3 of these can affect the amount of oxygen which is getting into the bloodstream. So there we go to the next slide, but it doesn't just end there. Sorry, it does not just end there. What's happening now is that once the oxygen has gotten into that red blood cell, which is in the lungs, this blood cell has to flow through the rest of the body to get this oxygen delivered. And that's where the heart comes in. So the heart is taking the blood from the lungs. It's going to the left side of the heart, from where it goes to the major organs and the rest of the body. And then it returns back to the right side of the heart. So keep in mind that the heart is not one pump, but 2 pumps which are working side by side. And that has to be clearly understood to understand what the problems are and how we are going to manage them in the future. So technically, there could only be 2 problems. Either you're not getting enough oxygen down to the lungs, or you're getting enough oxygen there, but that oxygen is not going from the lungs to the rest of the body. Yeah. So what can cause a problem which keeps oxygen from getting to the lungs? It could be that the atmosphere doesn't have enough oxygen, like you're on the top of K2, let us say. The other thing would be somebody has had a brainstem stroke and as a result is unable to take deep breaths. Somebody has taken narcotics, same thing. The brain is no longer telling the body to take breaths. Or they've got obesity, hyperventilation, where they can't take deep enough breaths and they can't get rid of the air in and out well enough simply because of the size of them. And of course, the people where the muscles have become so weak and wasted that they cannot take deep enough breaths. Okay. And in all of these cases, you will find that not enough oxygen is actually getting to the lungs. On the other hand, it could be that the oxygen can get to the lungs, but the problem exists with the lungs, like pneumonia, where there's fluid which is now collected in the alveoli a little bit. And so that little layer we talked about has become a bit thicker. There's pus and other stuff there. So that alveolus is no longer able to function as it used to. Yes. Similarly, if somebody had got COPD, as you could see, unlike a healthy lung, a COPD lung has got scarring. There is stuff like secretions in the airways. The alveoli themselves are damaged. And so as a result of all of that, they are not functioning as well as they ought to. Now, the lung is unique in the fact that when part of the lung stops working well, it actually makes sure that the blood supply to that area reduces the blood flow. So a non-functional lung will automatically divert blood flow away from the affected part of the lung. That is It's a mechanism to make sure that the work your heart does doesn't get wasted. And that brings us to the third problem, where what you have is a clot in the blood flow. So even though the air is getting to the lung, the problem is it cannot actually be delivered to the rest of the body because there's no blood flowing through carrying that oxygen from the alveoli. And of course, the example is a PE here. So key things to keep in mind in these conditions, there's not enough oxygen getting into the blood because the lung does not have enough functional parts or the blood is not flowing through them. And all these conditions will respond to increasing oxygen. Then we have got other conditions, like somebody has got a pleural effusion, or they have got an pneumothorax, same thing, it collapses the lung from the outside, but it makes the lung unable to do its job. Similarly, you can develop severe pneumonia in ARDS. If you remember the last picture, it looked like there was a little bit of pus in there, but now it looks the whole thing is full of fluid, yes? And of course, the last but not the least, problems with the heart itself, like congenital abnormalities of the heart, or holes in the heart, or MIs, or heart failure. All of those will cause problems with oxygen getting from the lungs to the rest of the body, okay? So what your physicians will do at this point is they will start doing x-rays and they will start doing arterial blood gases to try and figure out which one of these causes it is. And while you contemplate that, what they're really trying to do is, the first thing they will look at how much oxygen is getting into the lungs. So they're looking at the fraction of inspired oxygen and how much of it is actually getting into the arteries. That's what they're looking through the ABGs. And when they compare the ratios of these, they can come up with an idea of how big the problem it is that they are facing. I'll talk about this later, but just keep this thought in mind. And while I give you a little break, Shabana will start in the next few seconds. Shabana, I'll mute myself and then you can start.
Shabana is still muted. Okay, there she
Yes.
is.
Okay. So thank you so much, Dr. Mohsin. So just to recap, the role of alveoli and its function of exchange the gas is one of the prime, very, very important function of the lungs. So if there is any issues like any problems, pneumonia, pneumonia, or any COPD that may affect alveoli to not to do their proper job. So back to Mrs. N now. So what's going on, as we mentioned, that her vital signs are not in a normal ranges. Patient was drowsy and anxious. And Dr. Mohsin mentioned that any patient who is drowsy, anxious with a deranged vital signs should be a click on your mind that something is going on at an oxygen level with the patient. And then she was also complaining of abdominal pain. Let's not forget that as well. So the immediate action that as a nurse we did was we started the patient with oxygen therapy. So let's go through and see what are some of the modalities, some of the way we can provide oxygen to a patient who has decreased oxygenation in the body. So there are some conventional, some old method through which the oxygen is administered to a patient. The first one and a very common one is the nasal cannula. So nasal cannulas are used to deliver oxygen with a low flow, but a low or medium concentration when the oxygen concentration is required. And in that case, patient should be stable enough to breathe. They deliver oxygen in a variable manner. This means the amount of oxygen inspired depends on patient's breathing rate and pattern. If patient is hyperventilating, breathing more and more, they will get more oxygen. So for this reason, they are not suitable sometimes to use in an acute phase of illness when patient is really hyperventilating, having shortness of breath. Nasal cannula cannot be a good option. And the flow rate for nasal cannula is 1 to 4 liters per minute. And it gives you an oxygen concentration of 24 to 40%. So flow rate can go up to 6 sometimes, but this will affect and cause some nasal dryness. Remember, we talk about the humidification, which is very, very important. And that humidification starts right from the nasopharynx area. So more oxygen can dry up the layers of nasal layers, and then can be uncomfortable for the patients. So this may not be a very good modalities for us. But the advantage of nasal cannula, of course, a patient that it can eat, drink, talk, and they also reduce the risk of carbon dioxide rebreathing. So they're just breathing in and breathing out as a normal. As I said, dry nasal passage can be a problem initially, but with continued use, it can resolve itself. The second important modality is about the simple face mask. The simple face mask is just a disposable mask, which is made up of a clear plastic to provide oxygen therapy for patients who are experiencing conditions such as chest pain or dizziness and minor hemorrhages. This mask is only meant for patients who are able to breathe again on their own, but who may require a little higher oxygen concentration than the 21% of the concentration which is present in the air. So the simple face mask can deliver high flow rates than nasal cannula, like 6 to 10 liters per minute, and the FiO2 could be like 40 to 60%. So final concentration, the oxygen concentration, which is delivered by a simple face mask, is dependent upon the amount of room air that mixes with the oxygen in the patient's breaths. The air mixing is determined by how much air any individual is breathing at that moment. So the face mask has some holes so air can enter the mask, and this feature eliminates the danger of suffocation if the mask just gets disconnected from the oxygen with the tube. And with the mask, it is difficult to eat or drink, and it may be confining for some patients. Some patients may feel claustrophobic, so they may not keep on putting the mask on all the time. So you see that just keep on removing, and you are not able to deliver the desired amount of oxygen to those patients. So the partial rebreather mask, they look like a simple face mask, but it is connected to a plastic reservoir, a bag, which is filled with the high concentration of oxygen. And that mask has just one-way valve system that prevents exhaled oxygen from mixing with the oxygen in the reservoir bag, which is a pure oxygen. So when you inhale, you breathe in oxygen from the reservoir bag when you use a partial rebreather mask. The non-rebreather mask is a mask with a reservoir bag attached, and it has 3 one-way valves. 2 are on the front of the mask, and the third one is between the reservoir bag and the mask. So that allows a patient to exhale carbon dioxide out of the 2 holes, but not be able to breathe in air from the room through those ports. So by not allowing the patient to breathe in air from the room, which could dilute the concentration of oxygen. So this makes you to deliver 100% of oxygen as long as the flow is like 10 to 15 liters of oxygen. So you see, if you remove the valves, this will become a partial rebreathing mask, which can deliver 50 to 60% of oxygen. And if you remove all the valves and reservoir, it will become a simple face mask, and it delivers 40 to 50% oxygen depending on liter or the flow of oxygen. So the rebreather mask is extremely important because the flow is never set lower than 5 liters per minute. This is very, very important. We have seen sometimes the nurses are hanging those masks, but they are not setting up the liter of oxygen on a proper amount. So because you need to have that much of flushed exhaled carbon dioxide, which is in the mask, to remove out. Otherwise, patient will be rebreathing his own carbon dioxide all the time. So like face masks, partial rebreather mask and non-rebreather mask could make patient claustrophobic to the patients, and they may be feel a little hot and confining. Patient cannot eat or drink, they interfere with those functions, and they covers the nose and mouth, and it does not put a complete seal around it. So sometimes the air just keep on escaping out of it. So that may become an uncomfortable situation for the patient. Ventimask again is known for we call it an air entertainment mask because it's a device that delivers a known oxygen concentration to patients on controlled. Patient can be on controlled oxygen therapy with that. So Ventimask mixes oxygen with room air and creating a high flow enriched oxygen of a desired concentration, and it provides an accurate and constant FiO2 despite varied respiratory rates and tidal volumes. So we can have FiO2 delivery rate from like 24, 28%, 31, 35, 40% of oxygen. So we have the calibrated delivery of FiO2 between 24 to 50%, and they are mostly helpful for patients with the COPD, as they allow the PO2 to be titrated. So thus we minimize the risk of carbon dioxide retention. There's another method which for the pediatrics patients, I'm not going to be covering in a lot of detail, but it's an oxygen hood. This hood is like a plastic dome or a box with warmed and humidified oxygen inside. And the oxygen hood is used for babies usually who can breathe on their own, but still need extra oxygen. Somewhere they use oxygen tent, which consists of like a canopy, which is placed over the head and shoulders to cover the entire body of a patient to provide the oxygen at a higher level than normal. Amber bag is one of the most important mediator for the oxygen delivery. It is sometimes known as the manual resuscitator or self-inflating bag. It's a handheld device that's commonly used to provide positive pressure ventilation to patients who are not breathing or are not breathing adequately. So with squeezing the bag, you forcefully push the air in the amber bag, and which is they're used in the emergency situation. So the technique of bagging is very, very important. Giving too much volume or going too fast could push more air in the stomach, resulting in gastric insufflation. This could lead to vomiting, subsequent airway obstruction, or aspiration. And also the position of the patient, the position of the airway, and to maintain that proper position is very, very important when you are using the amber bag. The selection of the size of the mask is very important. Of course, you cannot be amber bagging a adult patient with a pediatric bag. The seal is very, very important. And as an ICU nurse, this competency is one of the most important competency to learn, as how to bag a patient, making proper seal and positioning of your hand, because you seal the patient's mouth with one hand and then you are bagging with another. And to be careful as that you are not over-ventilating and or hyperventilating. The another way of oxygenation is through non-invasive ventilation, in which there's a role of pressure through which the oxygen is forced and pushed into the alveoli, which Dr. Mohsin will be covering in further slides. So the last method is the invasive ventilation, which is you put the tube in the patient's mouth, or you make a hole on the neck area, which we call tracheostomy, through which we directly put the oxygen in the patient's respiratory system. Next slide, please. So now be back to Mrs. N. So far, whatever the situation was, we started her on a 4-liter nasal cannula. We gave reassurance to minimize her anxiety, which is very important, because when you're anxious, you're hyperventilating, which is not good. You are increasing the demand of oxygen in the body, using more oxygen. You can encourage them to take a deep breathing, so that will help going oxygen deep inside, and your alveoli will not rupture. The coughing exercises, as we said, the Mrs. N was complaining of some cough. It's very important to get the sputum out if she's making any. And then changing position. We will be talking about the proning and all those positions when we'll talk about ARDS. But changing position is very, very important, because sometimes the patients are keep laying in one position, just flat. They are not helping their lungs to inflate. So by not inflating properly, the more air is not going inside the body. So it's very important to encourage the patient to turn and take position on a side, or sometimes a high fowler, not to be in a supine position, to give enough gas exchange for the lungs. Of course, we will be monitoring the vital signs, and oxygen saturation is one of the most important parameters for us to know if patient is developing any deterioration from her condition. Neurostatus, as we mentioned, very important. As patient becomes more and more confused, more and more delirium, that means patient is getting more and more hypoxic, and sometimes we can get it confused with ICU psychosis, ICU delirium, or it's nighttime and all that. But no, if patient is confused from the borderline, patient was fine 2-3 hours ago, and now she's not talking in proper way, she's not cognitive, that is a bell in your mind that something is going on with the patient. And of course, we should watch for the oxygen toxicity. Too much oxygen sometimes is not good because it damages at the central nervous system level and at the alveolar level. So we will be putting some handouts for oxygen toxicity in the shared drive. Next slide, please. So back to Dr. Mohsin.
Thank you, Shabana, for again, a wonderful bit on how to give oxygen to patients. So balloons is what we're going to talk about. If any of you have got any at hand, we did ask that if some of you can bring along, now is the time to think about them and possibly blow some if needs be. But this actually, the first picture is outside of a lung. And when you think about it, both that picture and this one look very, very similar. And this is going to be very useful in understanding of what's going on with the lung. So we've got a little video. I'm very grateful for my firstborn who was kind enough to make an animation for me because clearly I can't. And I will let you guys watch this. So what you have is two balloons which are being filled up with water, but one of them is filled up with water and oil. Yes. And then what you do is you go ahead and put a straw down and you try to drink all the water out of that balloon. So one of the balloons will be left with just oil in it, whereas the other one would collapse completely. Now, why I have shown you all of this is that if you were to replace that water with oxygen and the oil with air, it tells you what happens to a lung in every breath. Because as you breathe in, your lung is full of both nitrogen and oxygen. And as your body carries away the oxygen from the lung, the size of the lung shrinks a little bit. Yes? But the nitrogen is there to make sure it doesn't collapse completely. On the other hand, when you replace that nitrogen with oxygen, as you do when you're giving somebody 100% inspired oxygen, what happens is as the blood carries away the oxygen, the lung really loses its volume. Yes? And that means that your balloon, if you're imagining the balloon analogy, has gone to being half full to being completely empty. And that has implications on how hard you have to work to fill your lungs up again. Yes? But here's the next question for you. So Mrs. N is on 5 liters or 6 liters of oxygen via nasal cannula. She continues to look anxious. She's a bit tachypnic and her SATs are still low. So which of the 5 following would you try to offer her next, especially in the light of what you've just heard Shabana say? So again, the poll is going to start and we will give you 30 seconds. Okay, so that's 30 seconds. And most of you have chosen the face mask as the first choice, which is a reasonable first choice. That you go ahead and escalate in a structured way to say, okay, fine, nasal cannula is not doing the trick. Let's go to the face mask. On the other hand, if there were signs which are concerning to you, that this is not really going to go to plan, then fair enough, you can go to higher modalities, but I certainly would not jump to CPAP at this point in time. The other thing to keep in mind with these patients is when you're concerned that their oxygen needs are going up, make sure that you're not offering them food and drink, because that might complicate matters if they need to be put to sleep or put on a ventilator. Yes? So just keep that little fact in mind. And we will go on to the next slide. So, as you saw, the patients, a lot of you chose that the face mask is the next in line, and so that's what should be offered. Some wanted the reservoir mask, which is reasonable enough as the next step. I would not give nasal high flow because of 2 things. One, it consumes large amounts of oxygen. So if you've got large number of patients in hospital, who end up on nasal high flow, there have been instances, at least in the UK, where the oxygen supply has failed. So I would really shy away from using these unless you knew that you had enough oxygen and not many people were, what the oxygen use was in the hospital at that time. And CPAP, of course, we will talk about a bit more in a sec. So, you know, the balloons I just said, if any of you have them, I think now would be the time to try and blow them. So I use that with my own nurses when we're doing the CPAP talk. I can give you a few seconds if somebody's going to go ahead and practice it. And in the meanwhile, if you have any questions, I can answer them for the next 10 seconds. Or if you want to share your video blowing the balloon, you're very welcome to do that.
Listen, there is a question. Shall we use high flow nasal cannula without CPAP or BiPAP?
Shall we use high flow? So the high flow cannula, as I said, so evidence is lacking. Usually it depends on individual practices, but we do know that it does become more comfortable. The patients find it easier to tolerate a nasal high flow cannula as opposed to CPAP. So if you feel that anxiety is the bigger part and the oxygen need is not that bad, then fair enough, you can try the nasal high flow. I wouldn't really jump to CPAP right away, but just keep in mind that if you've got 50, 60 people on nasal high flow, then your hospital might be in trouble. Okay. But certainly I do find that before COVID, my usual practice would always have been to try high flow if conventional means of oxygenation have not achieved the desired goal. Okay, so for those of you who have blown balloons and for those of you who have not had the opportunity, we are going to go to the next bit. So for those who started blowing balloons up, I'm sure that those who have not done it right now have done it in the past. Would you say it's very, very difficult to start off early when you're first filling a balloon which is completely empty? Is it hard to blow into it to start making it blow up with air? I think there should be some questions showing up, but they aren't, so fair enough. And usually the answer I get to that is yes. Starting to blow an empty balloon up is more difficult. But as you blow up some air in it, it becomes easy. Here we go. Here are the questions. So if you don't mind answering those, so the questions really are, at the beginning, is it harder to blow air into a balloon? As you blow some air in the middle, does it get a bit easier? And in the end, does it become harder again? So answer is true or false to all three of them. And I'm so glad to say that you guys are kind of representing what I normally see. In terms that most of you, almost 94% of you have gone ahead and said that yes, it's true to all three questions, which is that it's harder to start, it becomes easier in the middle, and it becomes hard again at the end. Yes? And here are some pictures to just reinforce that idea. Okay, so what you see underneath is a little graph, which is showing how the volume of the lung of the balloon changes as the pressure changes and somebody's blowing into them. And as you can see right at the beginning, she's really working hard. And if you look at the green part of that curve, you could see that the volume is not really, there's no vertical lift there, even though the pressure is changing quite a lot. And then you go to the red bit, which is here, where the pressure is shifting, but the volume is really shifting, changing quite a lot more with less change in pressure. And then you go to the very end where you've come to the end, and now what you're really thinking is any more and this will burst. Yes, and you're finding it a little bit more difficult to blow in. This is what's really happening with your lung as well. And when you're trying to give them CPAP, what you want to do is the lung has ended up on the green side of the cycle, because what's happening is that the amount of work you're doing to make it expand is really not doing it. And so what we do is we push air down the lungs. And that what it does is it moves the compliance of that lung. It kind of fills it halfway, so it doesn't really empty. And so it becomes easier to fill that lung up. Okay. And then that's how we try and achieve to do this. Of course, making sure we don't put so much pressure that you end up in phase 3, which is the yellow bit, where you can actually burst the lung, because people have managed that. And this is what I have saved you all from trying to understand. This is a horrible diagram, which you will see anywhere when you try to understand how to deal with lung mechanics. So how do we do it? We do it by putting them on machines, which have got devices to make sure the pressure is maintained, that the flow is there. They can see how the person is breathing in and out. But we will go into the depths of how the devices in the patient direct when we talked about invasive ventilation, which is 2 talks down. Now, in some hospitals, rather than use devices, or the machines, they've got devices which plug directly into the oxygen supply. There's no machine needed. And the circuit is for that patient to be used once and then discarded. And there again, you can't make as many changes. You can't be as fine in your changes as with a machine, but it's a cheaper and much more easier way of delivering CPAP. There are different kinds of masks for CPAP that are used. And as you can see, there are nasal pillows. There's a nasal mask, which sits just on the nose. There's a full face mask. There's a hybrid, which covers the mouth and the lower bit of the nose. And of course, there's one which covers the mouth for those who breathe through their mouth. Now, all of these have got their own limitations, their own benefits, and it depends on what's available in your institute, which is compatible with the device at your institute, which you need to be really good at. And the way you go about that, of course, is that there should be training available for what devices are available where you work. Now, the last thing is the hood. The hood is actually better tolerated than the masks, especially in people who are claustrophobic. But keep in mind that putting the hood on has its own complications. And there is issues about aerosolization when it comes to patients on large wards with COVID-19. So back to Shabana here. Shabana? Okay.
Okay, next slide, please. So the indications for using the CPAP, the first one is the obstructive sleep apnea. When the patient sleeps and the areola, the airway get obstructed, so that's one of the conditions through which we can use the CPAP. The other is heart failure, because in patients with CHF, the BiPAP can improve the hemodynamics by reducing the preload and afterload. However, it may cause hypotension at the same time, so you have to be very careful for that. Another indication is to use when patient is an atelectasis, because what's happening, there is no additional pressure coming up. So in CPAP, no additional pressure above the set level is provided, and patient has to initiate all the breathing. So the application of CPAP maintains the PEEP, and this prevents the atelectasis, increasing the surface area for the alveolus for proper exchange of gases, and that improves the oxygenation. The other one is from weaning the ventilator. If the patient is on invasive ventilation, the mechanical ventilation, if you want to give a try, if patient can tolerate the extubation, this is one of the mode of ventilation that you use, the CPAP mode, to see how patient is breathing and is he ready for extubation. And of course, the pneumonia. CPAP does not treat the pneumonia, but it reduces the work of breathing, which we always see in the pneumonia. Next slide, please. So yeah, we should not be giving a try of a CPAP if patient is really, really hypoxic. If patient needs an invasive ventilation, we should go for that. Next slide, please. So some of the contraindications that we have, that we cannot put those CPAP masks on those patients, and one of them is the low GCS. Of course, if the patient is not breathing and you think the patient is going to be more and more drowsy and he's not getting, taking over the function of breathing, then the CPAP is not a good option for that. If the patient is not able to protect the airway, it getting obstructed, again, the CPAP is not a way, because as we mentioned, in CPAP, patient has to breathe, initiate the breathing on its own. If there is any facial trauma, any abnormalities, you cannot put the mask on the face, so it's not a good option for the patient. Vomiting, if the patient is going to vomit out and you have the mask on it, he's going to aspirate everything in the lungs, which may be a cause of pneumonia. So this is not a good option for the patient. Hypotension, as we mentioned, that the CPAP effect on the preload and afterload of the heart, and it may reduces the blood pressure. So if patient is already having a systolic pressure of less than 90, it will decrease the pressure further. So this is not a good option if patient is on hypotension and you put the mask on the patient. If there is a pneumothorax, as we mentioned, that the lungs are not moving up because of the restriction, because of air in the lining of the lungs. So of course, you cannot CPAP is not going to help, because this is going to put more positive pressure on the lungs and increases the pneumothorax on those patients. Poor fit of the mask, because some patients are not a good fit, that it comes in different sizes. And if there is a possibility of having the air being leaked out from the mask, then it is not a good option for the patient. Severe pulmonary fibrosis, as we mentioned, if at the pulmonary level, alveoli level, the alveoli are not getting opened up, they're fibrotic, they are not having the function of exchanging the gases. So it's not a good option, because you're putting more and more pressure, more and more air in the lungs, and it keep on accumulating inside the body, inside the lungs. And of course, the dementia, because patient will keep on removing the mask all the time. You will see a beep and pump. The event is alarming. You are not providing enough pressure, so you are not fulfilling the purpose. So there is no good way to put the mask on a patient who is having dementia. Next slide, please. So as Dr. Mohsin mentioned, that all these masks and how the CPAP machine work, it comes as a guide. As of now, we are not sure. There's so many devices, so many machines in the market. But the important thing is that how to choose the right size of the mouth of the mask, which is very, very important. You cannot put a very small for a very big, the mouth, the area, the facial area, which is not going to serve the purpose. And then again, you have to follow the manufacturer's guide of how to pick up the proper mask. Next slide. So these are some of the common complications when we put the patient on CPAP. As we say, patient become claustrophobic because there's a mask with a lot of pressure on the face. They may become claustrophobic, and they may not have you put the mask on all the time. Of course, the skin irritation, because the mask has to be tightly fit on the nasal and mouth area. Sometimes it breaks the skin, and we have seen many patients with so many skin tear all over the mask, especially the nasal bridge that we have. Sore nose, because the air is going from the nose with a great pressure, and as we said, that this may dry up the mucosal layer of the nose, then that may become nose to be sore. Dry air leaks, very, very common problem. The air is leaking out of the mouth if that's not tightly fit, and if you fit tightly, they get skin irritation. So it's really a challenging situation for an ICU nurse to keep up with that patient with the mask on and air is not leaking out. The stomach bloating, sometimes if patient is not breathing enough and you have a lot of oxygen, a lot of pressure around, goes from the mouth down to the stomach, and you see the air in the stomach. So may give you a feeling of bloating, chest or lung pain. When there is enough more oxygen in the lungs, it irritates the mucosal layer of the lungs. That may give you a pleuritic chest pain kind of feeling because of the more oxygen. And there is some chemical reaction happening at all the cellular level because of more oxygenation in the body. So that's something we are talking about, oxygen toxicity. So sometimes patient will complain of chest pain, which is not a cardiac related chest pain, but it's because of the pleural chest pain because of the oxygenation. And of course, the dry mouth and throat because of the oxygenation, we already covered that. Nasal congestions and eye irritation. You can see how the mask is fit on right by the air, but the eyesight, and it may cause irritation because all the pressure is coming out of the mask to the eye area. So this is a good guideline about how to quickly care for a patient who is on a CPAP. So if patient has an acute respiratory distress or a surgical emphysema, then patient saturations are dropping for more than 3% from the baseline, or there's a drop in the GCS, how it goes on and on with that. And there is a gastric abdominal distension, there is a nasal dryness, vomiting, aspiration, and there's a pressure damage. So peri-arrest, just we have to call everybody to get the help. We have to increase the oxygenation and follow the chart. What is the best oxygenation modality that we use? Consult the doctor. You have to hold the sedation if patient is on any kind of sedation that we are giving him to put on him sleep, because that may increase the work. The patient is not breathing enough to grab the oxygen and having that oxygen go down in the lungs. Sometimes we may have to insert an NG tube, because that may remove the air out of the stomach and decompress the stomach, which could help the patient. We may have to give 2-hour saline nebulizers or PRN, because as we mentioned, the nose gets so much of dry. So we may have to use a saline nebulizer for that. And if patient is complaining of nausea, you can ask for antiemetics for vomiting. And if nothing is helping, just disconnect the CPAP and start on 15-liter non-rebreather, and get back with the doctor to see if patient may need some high level of oxygenation to preserve the functioning. Next slide, please. So we already mentioned that the oxygenation decision when it comes to a COVID patient, as you know, that when we started with the FiO2 of 5 liter, and then which continued the care. We did the proning of the patient to expose the lungs, to give them the more space for the lungs can breathe in, and then patient started deteriorating. The FiO2, we tried to increase it to a FiO2 of 10 to 15 liter per minute. And then when that steps come, you should already start thinking of CPAP or putting patient on the ventilator, which we'll be covering later on, later sessions. So if you see the FiO2, you have to give a FiO2 of 60% and 90%, then just start thinking about CPAP. Just do FiO2 if it's less. If it's you need to give the oxygenation with the FiO2 of more than 55%. The other important feature for nursing is to continue proning position if not contraindicated. Keep the intake and output strictly, because those patients are put on diuretics as well because of all the consolidation that we see in the lungs. Saline nebulizers, as we mentioned, and then you have to keep on titrating. Look into, if you put on the CPAP, increase the FiO2, give it 2 hours at least. If you're not reaching your target oxygenation within 2 hours, definitely call the doctor, and this may be a time to increase our oxygen modalities. Next slide. So when a nurse comes in from the start of the shift and you have a patient with CPAP, these are some of the important checks, safety checks that you should be doing as a bedside nurse when you are taking report. Ideally, I know it's a COVID season and we are trying to reduce all the PPEs, and otherwise we encourage the nurses going inside the patient's room and checking on all these settings while with the leaving nurse, so you all are at the same page about the settings and lines and everything. So yes, you confirm the CPAP setting, what the settings have been ordered by the doctor, and are those settings on the machine or not. If you see the oxygen supply is properly connected, that is no king, they are correctly there on the correct outlet, they are on the oxygen and not on the medical gas or a suction valve. Sometimes in a panic situation things may happen. Make sure all those supplies are on the oxygen outlet. You have to check there is interference in the circuit. It's all through. There is nothing that can interfere with the flow. Check the mask, which is fit and it's not leaking. It's not all the areas of the mask. You have to check for the skin underneath the mask to see if there is any skin, the pressure ulcer or any tear or any skin is getting compromised. For that, you may put some gauze or some kind of deodorant sometimes that may help to give a pad to those skin, which are very sensitive and may get injured. So those pads, those deodorants sometimes help to avoid that situation. Of course, the humidifier is very, very important. We have to see that if patient is on a saline nebulizers. If not, you can request the doctor to order that. And the very, very important, you should have the rebreather mask available by the bedside. If patient is very, very confused, throwing the mask away and you cannot come out, you are all gowned up and all, at least you have something to start on the patient so patient doesn't get compromised. Because remember, we are talking about the patient whose saturations are very, very low and they can crash anytime. So you should have a rebreather mask and an ambo bag in the patient's room all the time. And of course, we have to make sure the patients eat. with the NG feed, because you cannot afford to keep the mask on and off, to take 1 bite, 2 bite, take the mask off and put the mask back on. Sometimes it doesn't help, and you cannot put the other oxygen with the high flow, because remember, we don't have to give a very, very high amount of oxygen with the masks and all that until it's an emergency. So the NG feeding is the one of the strategy that you can use to keep on feeding those patients. Those patients really need protein and more to get over on the insult that the body has because of the disease process. The sleep chart, very, very important. Those patients need to sleep. If those patients are keep on awake all the time, of course, they will be tired. And once they are tired, they will not work or participate in the function of breathing. So melatonin is one of the medication, one of the kinds that the doctor can order, so they can sleep in the night, and in the morning, they can start working with the nurses for the weaning process, weaning trials, and we can wean them down from CPAP to other lower modalities, and we can get the CPAP off. And of course, the intake and output charting, and we need to make sure that we are balancing it. A little bit on negative side is better than we keep on accumulating fluid in the body, and the lungs is not able to carry that kind of fluid in the lungs. Next slide. So this is the handout, and we have this handout in the other shared drive as well about the proning. It is very, very important, very, very effective. You don't have to prone the patient who are just on the ventilator. This is something that you can give to the patients who are on the oxygenation, COVID, how they can help by turning themselves. They can make a chart for themselves. Okay, 2 hours on this side, then 2 hours or 1 hour straight, and then another side, and the prone and sit down. So patients sometimes do participate in those kind of care when they know, and when they are given those kind of timeliner or planner to them, and they participate. That can help their oxygenation level in the body. Next slide, please. All right, so we are back to Mrs. N now. So the next day when you came, she was on CPAP. We saw that, we left her, you gave the report to your nurse. Now when you came back in the morning or evening shift, you saw that Mrs. N is getting more and more anxious. She's more and more confused, disoriented again. And she's trying to pull all the leads, the masks, the IVs and everything. Her heart rate has increased to 140, and the respiratory rate has increased further. Now she's been in labor breathing. Her oxygen saturation is 70% now. So what should trigger in your mind when you see these kind of vital signs and this kind of condition on Mrs. N? You went to see the doctor, and the doctor asked you to do the blood gases, and he ordered an chest X-ray. And after, when you send the blood for the ABGs and chest X-ray, here is what you got. Dr. Mohsin, you want to go through that?
Yes. Thank you, Shabana.
Mohsin, we are 7 minutes over, just so you know.
Okay. Just quickly to let you guys know, in that case, what we have done was we have identified that the lungs have got markings all over them, and you can see that there's not enough oxygen getting into the patient. So this patient ideally should not be considered for invasive ventilation. But the next talk is going to very much focus on what's happened to the lungs, and then we will talk about that. So just keep that in mind. And just a few reminders. These are the handouts that you have available now from the first talk. These are the handouts that you have from the second talk. And again, they've got everything that we have talked about already there. So you don't need to worry about what else you need to have. We are short on time. We have run over already. So any questions you have, please do post them. We will make sure that in the next session, we answer your questions as we start and address those sooner rather than later. Of course, in the last session, again, which is focused very much on question and answers, we can repeat the whole thing all over again. You will need to give us those feedback forms, because that is what we are going to use to be able to give you your certificates. And so please do the feedbacks, because that is how we improve. We know what's going on, and that is how we can actually give you the certificates to say that you have spent an hour of your life with us and you have learned something from us, hopefully. No, that's not you. This is the end. Thank you.
Okay, thank you very much. And, there are questions. There are 3 of them here, or at least 4 of them. We will be answering those in the next session. And as Dr. Mohsin said, please send the feedback forms. Your attendance will be counted once the feedback forms are back. And next week, we are going to start this session 15 minutes before. So it'll be at 6:45 because we have realized we need more time.
Thank you.
So thank you very much for attending, and thanks for all the enthusiasm.